All right, we're gonna go ahead and get started. Evening, how's everybody doing?
Good about yourself.
Oh, can't complain with nobody listen anyways. So this is gonna be for chapters 1 through 5 lecture today. Good news about these chapters is there's a lot of very basic information. Uh, so there won't be just a whole lot of time that we're gonna have to dwell on a lot of this stuff. A lot of it's pretty introductory stuff. And then it'll also be recorded and published onto our YouTube page, which I'll get the link for that sent out to everybody uh, this evening or first thing in the morning as well. Before we get started, does anybody have any questions about anything so far that's been trying to get set up or anything like that?
I don't. Everything I've been doing's been going through.
Everybody had a pretty easy time getting some stuff. I know there was some delays on the books, but I think those that's pretty well been taken care of. Anybody got any issues so far? Oh, all right, very good. Well, we're gonna start off right quick on chapter 1. I'm gonna put everybody on mute just so that there's not any background noise. If y'all need to ask a question, feel free to unmute yourselves and then ask your question, and you can stop me at any point in time to ask a question. This is not a super formal task or anything. All right, so chapter 1 covers the introduction to emergency medical services. So EMS began, its earliest roots can be traced back to the late 1700s, early 1800s. It began when the French started using designated people on battlefields to transport wounded soldiers away. And they would actually have doctors that followed their armies and would care for troops that were wounded in combat. This is a pretty revolutionary idea at the time because back in those days, usually whenever you were sick or you were injured, there were doctors, there were physicians, stuff like that, but they didn't often follow the military. They didn't often follow combat or chaos or respond to any kind of emergency situation. Usually they were there, but you had to get to them. So having some people that were actually able to bring the wounded to physicians kind of started back around that time with the French army. This continued on in through several conflicts. Was further developed in the United States during the Civil War. Uh, Clara Barton established the American Red Cross a little whiles after the war, uh, but she was very instrumental in organizing a nursing corps and an ambulance corps, essentially, that was responsible for removing the wounded from the battlefields back to surgical centers and medical units that were stationed behind the front lines in order to provide aid on both sides. As the world became a little bit more modern and technologies became a little bit more advanced, we entered into, the World War I era, and the Red Cross developed a volunteer ambulance corps. This was essentially the same mission that their predecessors had with the French and through the Civil War and things like that. But they would actually utilize, motorized vehicles and would drive them a good ways away from the combat action, or would carry their litters, across battlefields and everything else under fire to get them to medical care. Fast forward a little bit, we started learning a little bit more about what we were doing right, what we were doing wrong through EMS. We get into the Korea and Vietnam era days. Uh, in Korea, we first started to see it. I don't know if anybody's watched the TV show MASH, but MASH was about a mobile army surgical hospital. That's what MASH stands for. Uh, and these MASH units were set up, throughout Korea during the Korean War, and they were designed to provide forward surgical and advanced resuscitative care, advanced life support care, in a combat environment. Which up to this point, surgical and medical care provided in a combat environment was very basic. You had your corpsman that would essentially provide some basic first aid on the field, and then you were just there until a volunteer could get you back way behind the line to a hospital, usually in a town, a couple towns over, or the closest safe area they felt that they could get get you to for medical treatment. So as these MASH units started coming about, we also started seeing advancements in field medicine. And these MASH units were instrumental in developing new protocols for combat medics, which then transferred over into the civilian side of things. Because, as the wars end or people rotated back from the wars, they were bringing back the knowledge that they had, and they were starting to apply it in the civilian aspect of things. And civilian government was taking notice of improved survival rates and increased levels of care that were being provided to soldiers, and trying their best to implement that stateside as well. Uh, non-military ambulance services were already operating, by the Korea Vietnam era, but they were very, very old school. They were very minimalistic. They did not provide a whole lot of actual treatment. They were meat wagons essentially. That you would throw them in, and they would, haul butt over to the closest emergency room or receiving hospital, and would drop somebody off. Uh, they did not develop into smaller communities until, the mid to late 1900s. And up until, pre-Korea, Vietnam, a lot of times they were operated by either local funeral homes who would just double use a hearse for two different purposes, or by fire departments who had developed an ambulance because they saw the need in their community and started operating an ambulance to get people to hospitals. Um, as time went on and advancements in medicine, progressed, there was an obvious need to take a lot of the training, a lot of the advances we had made in a military environment and apply them to a civilian environment. There was, there's that, motor vehicle accidents, cardiac events, shootings, stabbings, everything else was also happening right here in the United States. So we knew what we're already making these advances overseas. We're already making these advances in combat zones. Surely, if we can do this stuff while we're getting shot at, we can do it on the streets of Detroit or, Chicago or Little Rock or wherever without having too big of an issue. So that's what they did. They started developing standards of training and everything else for EMS. So around the mid 1960s, the Department of Transportation was charged with developing a set of EMS standards. And this was the first real solid base of regulation that civilian EMS standards had to go by. This is where a lot of your certifications were born from, such as, emergency medical technician and paramedic. A lot of them had their roots in the standards that were set by the DOT. Fast forward as that kind of took off pretty quickly. Fast forward to 1970, and the National Registry of EMTs, or the NREMT, organization was developed. The NREMT was designed to be a training and standardization agency. So they compiled a set of standards, training standards, and everything else that they felt would be applicable to EMS providers across the nation. And at first, they were a voluntary agency to be affiliated with, and they would just do their best to try and get everybody on the same page. So that way, it didn't matter if you were calling an ambulance in New York City or Jackson County, Arkansas, you could get an ambulance there that was proficient and trained on a standard scale, and you could have the best chance you could hope for survival. In 1973, the National Emergency Medical Services Systems Act, that's a mouthful, was passed by Congress. This kind of gave a little bit more structure and stability to EMS, as well as recognizing them as first responders in a larger capacity than what they were recognized before. Uh, Through this, there started being regulation and policy. So each state, the way that's kind of started setting up and the way it still operates today is each state will have a regulatory agency that establishes laws and functions as a lead EMS agency for regulation of state providers. Uh, this state agency coordinates funding, policies, procedures, regulations, handles licensing, handles complaints, handles anything like that at a state level for EMS providers in that state. The EMS systems also started utilizing resource management. So these state agencies would help kind of coordinate a very standardized emergency treatment and transport resources platform. So that's where you started seeing your mutual aid agreements and other things like that. So there was always some sort of EMS coverage available in most communities. The state agencies were also responsible for human resources and training, so ensure that EMS personnel are trained and certified to the minimum standards and ensure that safe and reliable transportation was provided. A lot of states began and are currently relying on the National Registry of EMTs, NREMT model for minimum standards, safe training, good operations, everything else. The NREMT will publish guidelines on that pretty regularly and make updates as needed to those guidelines. And a lot of states are or have adopted those as kind of their state. Arkansas is one of those states that has adopted the NREMT model for how to do things. The standard of transport to the closest appropriate facility was developed through all of these changes and through all these regulations, which basically took out a lot of the issue that EMS providers were having, at first, and still face to a much smaller extent today, is people were wanting to be transported to their family doctor. They were wanting to be transported, clear across, you know, Timbuktu and three counties over to get to a hospital where, their Uncle Bob's best friend's girlfriend works as a nurse. And we were starting to see patients were having poor outcomes because they were not getting the emergency medical care that they needed right then. So it established a standard to transport to the closest appropriate facility and gave us some backing to stand by that. Uh, it helped access with the universal system access number, so 911. 911 became an access point for EMS as well. Uh, Also created standards for dispatch systems for EMS. Established public information education programs, and also established a system of medical direction. So, medical direction is where a physician, known as a medical director in the EMS system, is accountable and responsible for EMS personnel within the system. So, they're responsible for establishing protocols, policies, all that other things for an individual EMS agency. Everybody working for that EMS agency works under that medical director's license. So, for instance, with Pafford Medical Services, we have two main medical directors for most of the state of Arkansas. It's Dr. Seymour, who is our main medical director, and Dr. Wagenhauser, who is our associate medical director. So I, as a paramedic for Pafford, work under their licenses. So EMS systems are made up of several components. First component is the first line of an EMS system is always going to be dispatch. So in most systems, will have what's called an emergency medical dispatcher. Emergency EMS dispatchers or EMDs are a lot of times trained to the EMT level or greater. There's a standard of training that they must meet as well. Uh, and they provide as best care as they can over the phone while getting EMS resources en route and helping talk people on scenes through potentially tragic events. Then you have your EMS responders, which is what you see most all the time. That's your fire departments, your ambulances, your EMTs, your paramedics. Then you have the emergency department and the hospital, which consists of your doctors, your nurses, your allied health personnel. It's your definitive care stage. Some things to consider when dealing with transport of a patient, and we'll delve into this more as we start getting into more specific topics. There are specialized care facilities that we have to deal with on a pretty regular basis. Trauma centers being probably the most prominent one. So you'll learn what different levels of trauma centers and stuff mean as we go on throughout this course. There's also burn centers, pediatric centers, cardiac centers, stroke centers, and we'll talk more about that as we get a little more deep into those specific topics. So typical way an EMS system is accessed. Patient, citizen calls 911, maybe the patient themselves, connected to a emergency medical dispatcher, who then has dispatched emergency medical responders such as first responders, rescue, fire departments, things like that. EMTs and paramedics on an ambulance, emergency department staff, and then allied health staff follow up. Uh, so critical decision making is a very important skill that a lot of you probably already have, and if not, you'll develop as we go throughout this course. Uh, we make split-second decisions based on, secondhand unreliable guesswork is what I'd like to tell people a lot about what we do. So because of that, you need to have critical decision-making skills. You need to be able to gather information not just from your patient, but also by surveying your scene, providing a good assessment to what you can see, feel, touch, hear, smell, everything else, other sources such as bystanders, other information, other evidence that you can find at the scene. Then you need to be able to interpret that information and make decisions regarding treatment and transport of your patient. It's kind of like playing detective in a medical sense. Whenever you're called to a scene as an EMT or a paramedic, you need to be able to you need to be able to interview quote unquote witnesses. You need to be able to interview your patient. You need to be able to look for quote unquote evidence of what's going on and use all of these things to make a decision about what you need to do for your patient. You need to be, you don't need to be afraid to ask additional questions if you need more information. Ask as many questions as you feel is necessary. Perform any additional examinations or assessments that you feel are necessary in order to get the best information to treat your patient with. Some examples of this could be, should you take the patient to the closest hospital or a more distant specialty hospital? Are they stable enough to survive transport to a specialty center where they can get definitive care? Or do we need to get to the closest hospital to allow a physician and emergency department staff to further stabilize this patient before taking them on to a specialty center. It's a judgment call you'll have to make, and we'll get into, how you make those later on. Uh, will this medication that I'm about to give this patient, will that help their condition? Will it make their condition worse? Uh, how is this going to affect my patient? Is this going to help? Is this going to hurt? Those are always things we've got to ask ourselves. There's four general levels of EMS training and certification that you'll see throughout the United States. There's some states that have some that vary, but the general standard, the general norm, especially that's established by the NREMT, is the most basic level is emergency medical responder. Uh, Most people that are on fire departments go through some sort of first responder, emergency medical responder course. Uh, Through their fire department. It's generally a basic 40-hour or less class. Uh, Sometimes it yields a certification, sometimes it does not. The Arkansas Fire Academy, up until recently, was performing an EMR class. They've changed it to now it's firefighter first aid or something like that. Uh, but that's just your basic entry level first responder type training. You'll find that a lot with a lot of volunteer firefighters, police officers, sheriff's deputies, and the like. Uh, Then you have your first, what I call workable level of EMS training, which is your emergency medical technician certification, which is the class that y'all are in right now, is to become certified EMTs. Uh, it's the most basic. It's the most basic level of workable provider, but it does incorporate some higher assessment skills and a slightly larger scope of practice than what's possessed by an EMR. Then you have your advanced emergency medical technician. Advanced EMTs kind of bridge the gap between EMT and paramedic. So they're allowed to do a few more advanced level interventions, such as some IV therapy. There's a few medications they're allowed to give, and certain types of advanced airways that they're allowed to put in. And then there's a paramedic level, which is the highest level you get in EMS certifications. Paramedics are advanced life support providers. They're signed off by a physician to operate directly under that physician's license, uh, operate under a set of protocols, standing orders to provide advanced life support care, such as cardiac care, intubation, respiratory therapy type care, medication administration, narcotic administration, and so on and so forth. There's not a whole lot of things that paramedics can't do uh, in the field. As far as EMTs go, there's several key roles and responsibilities you need to be aware of. Excuse me. First and foremost, your own personal safety is paramount. You are not of any benefit to anybody else if you are not in a safe situation to provide care to anybody. Um, this takes form in a lot of ways. It's not just a scene safety type issue. It's driving and getting to the call. It's how you operate while you're on the call. Uh, it's how you take care of yourself in between calls. You need to be able to be safe and ready to operate at your highest capacity at all times. Uh, if the scene is not safe, and if it's not secure, you do not need to be entering into it. Because what good is it going to be if there's an assailant on that scene and you go in to render aid and now you become a patient yourself because that assailant has attacked you or that scene has become unsafe? It doesn't have to be a violent scene. You know, what happens if you roll up on a motor vehicle accident with power lines involved and you just trudge off in there because you think you're going to be a hero? Now you get yourself electrocuted. You can't help the people that are trapped in that car who needed your help. And now we've got to provide additional resources to help you as well. So your personal safety needs to be your primary concern at all times. Following that, you need to be able to be concerned for the safety of your crew, your patient, and bystanders. Whenever we are on scene, it is our scene until we hand it off to somebody else. If we're the first people there, it's ours. Uh, a lot of times on larger incidents, we will have law enforcement and fire department that we can delegate to some of these other responsibilities. And most of the time, we're not going to have to tell them to do these kind of things. They're just going to do them. But you need to always be cognizant of the safety of your crew, whether that's just you and your partner, whether you're responding on a fire department fire truck and you have 4 or 5 people with you, whether you're in a police car and you are riding solo, you have a FTO with you, or whatever the case may be. You need to be cognizant of their safety as well. Safety of your patient. One of your highest roles in this position is as a patient advocate. That means that you sometimes have to speak for the patient when they can't speak for themselves. And we're going to talk about that a lot more here later on. And as well as bystanders, you want to keep them from becoming part of the problem. So you don't want to have people running off in your scene or trudging all through everything and potentially becoming a hazard themselves, where now your resources are further divided because you have to take care of one more person, especially when that could have been prevented. Uh, in this role, you'll have to work with other public safety professionals on a very regular basis. You will have to work with fire departments, law enforcement agencies, hospitals, air ambulance agencies, emergency management workers, utilities agencies. I mean, you name it, you're going to have to come in contact with them at some point somewhere. Uh, you need to be able to have a good working relationship with them. You need to be able to perform a complete and concise patient assessment and provide care based on that assessment. And we will teach you all those skills you need to learn throughout this class. You need to be cognizant of safe lifting and moving of patients. Once again, it goes back to your personal safety aspect a little bit. You need to know how to move somebody and lift somebody without hurting them or you. Uh, you need to be cognizant of safe transport habits, know what appropriate uh, transfer of care really means, and you need to be a patient advocate, like I said earlier. So this question asks, could the concept of patient advocacy also extend to the community, such as fall prevention programs for the elderly, poisoning awareness, pool and water safety programs, et cetera, et cetera? The answer is yes. It absolutely will extend all throughout that. Being a patient advocate isn't just, stepping up and, defending your patient by, speaking up for them when they can't speak up for themselves. It could also be that you've responded to an elderly person's house and, so they've got a couple of loose little flimsy rugs laying on top of carpet and it's a fall hazard because you've seen people fall because of it. You make them aware of it. It's like, hey, if y'all thought about maybe not laying this here, about maybe moving this here, let's move these cords out of the way so you don't trip over them. Let's get your oxygen tubing wrapped up, whatever the case may be. Let's try and help prevent an emergency before it becomes an emergency. Same with dealing with children. If you respond on a call and you notice that there's medications or cleaning solutions and stuff in easy reach of small children, may in a very proper and professional manner, try and be like, hey, have y'all thought about maybe trying to put that out of their reach? Just different things like that. It's all about being a patient advocate and trying to prevent an emergency before it becomes an emergency. Talking about physical traits of a good EMT. EMTs do not have to be The Rock. They do not have to be track stars, but you do need to have a basic level of physical fitness. You should be able to lift and carry equipment and patients up to at least 125 pounds. You need to have good eyesight, whether that's corrected or uncorrected, for distance and reading. You have to read things on a regular basis. You have to read street signs, be able to look at things from a distance as you're surveying a scene. You need to be aware of any problems with color vision that could start posing a problem. You need to be trying to get those corrected. And then you need to have good communication skills, both oral and written. You need to be able to talk to other people very well. You need to be able to talk to each other well, talk to hospitals, everybody else you're coming in contact with very well. And you need to be able to have good written communication skills because the bane of this job is paperwork. Everything you do as a professional EMS responder is going to end in paperwork. Paperwork is terrible. It's awful. I hate it, but it is very necessary because it will save your butts in a courtroom. So you need to be able to have good communication skills to rely back on that. And we'll talk about that more during our documentation class later on this evening. Some personal traits of a good EMT. You need to be pleasant, sincere, cooperative, resourceful. You need to be able to be personable to people. Professional appearance will always inspire confidence. It is one of my biggest pet peeves, and it is something that I harp on people on my shift the hardest about is professional appearance. It doesn't take much to iron your shirt. It doesn't take much to tuck it in, make sure you're not covered in, dust, dirt, dandruff, whatever the case may be. It's real easy to not look nasty. It's real easy to not smell nasty. Soap is cheap. We can help you get it if you need it. It's not hard to get. It's just you're going into meeting somebody on potentially one of the worst days of their life. If you go in there all disheveled with your shirt half tucked in, smelling like you hadn't showered in 5 days, they're not going to trust you as much as if you go in looking like this pristine gentleman right here who has his shirt tucked in, it's nice, ironed, pristine, clean. He's got his gloves on, he's got his bag, he's ready to go. He looks like he's there to handle business, and that's going to inspire confidence on somebody who is having the worst day of their life. You need to be a self-starter. You need to be able to take initiative and perform tasks without having to be told to, constantly. You need to be able to know when to restock your equipment, to get up and go on your calls, to be able to clean and make sure your unit is in working order. You need to be emotionally stable. This is a very taxing emotional job emotionally. You will see some stuff in this position in this profession that nobody was ever meant to see. Because of that, you need to have at least some level of emotional stability to where you can cope healthily and effectively with any kind of emotional trauma you may sustain throughout this profession. You need to have good leadership potential. You may be responsible for directing yourself, your partner, other responders at a scene, bystanders, whatever the case may be. You may have to go show up on a scene and take charge and start getting things done in the best interest of your patient. So you need to have a good, calm, and professional demeanor to where you can take charge without essentially pissing everybody off. You need to have a neat and clean appearance, like I talked about earlier, and you need to be of good moral character and respectful to others. Uh, we're not in charge of very many things. And so it kills me when people walk into houses on 911 calls thinking that we own the world. We don't. We're coming into somebody's house because they need help. So you need to be respectful to that person. You need to be respectful to other responders. We're not better than anybody else on a given day. So it is unacceptable, in my opinion, for people to have poor tact and poor affect when dealing with fellow responders, firefighters, law enforcement, whatever that case may be, as well as dealing with patients, hospital staff. We need to be the example, not the exception. You need to be able to be in control of your personal habits, whatever that habit may be. I know tobacco use is very prevalent. This is Arkansas. It just is what it is. There's nothing wrong with tobacco use. Well, there are things wrong with tobacco use, but that's not my point here. Uh, Tobacco use is, I mean, people are grown, so they can use tobacco as they please, but it does not really look all that great if you walk up to a patient's house smoking a cigarette, or if you're trying to talk to a patient, do your assessment with a lip full of dip. Doesn't look good. Be able to be in control of your personal habits where you can forego nicotine, tobacco, whatever your personal habit is, not just those, but whatever your personal habit is, be able to forego that the duration of patient contact and dealing with other responders, just in the sake of having a good professional appearance. Because it all goes back to trying to inspire confidence in your patient who's potentially having the worst day of their life. You need to be able to listen as part of your assessment skills, and we'll delve into that. You need to be non-judgmental and fair. It does not matter what your personal beliefs or your personal biases are, what your political leanings, religious leanings, it does not matter. They are your patient and your patient only. It does not matter what they have done, what you see them as, it doesn't matter. You have to provide them the same standard of care as you would somebody you agree with completely and totally. You're responsible as an EMS provider to uh, maintain up-to-date knowledge and skills. That means attending refresher courses, continuing education courses, conferences, seminars, lectures, whatever you have to do to obtain continuing education hours. So many different places that you can work as an EMT. You can work in an ambulance service, EMS agency, work in a fire department, you can work on rural or wilderness rescue teams, you can work in an urban or industrial setting, such as in factories, working on a first aid team. You can volunteer through various organizations, whether that's a volunteer fire department or volunteer rescue squad, reserve law enforcement, whatever the capacity. You can work as an EMT in so many different ways. Uh, Talk about the NREMT. So quality improvement is a process through EMS systems in which we try to make ourselves better. So this is done through reviewing past calls, reviewing what happened, what could we have done better, uh, and how can we improve upon that. Because of that, everybody in the organization is important in a quality improvement scenario. That's why your documentation comes into play. You need to be able to have carefully written documentation so people can review it and say, okay, you know, Billy Bob did fantastic on this call, but he could have done this and this, and I think that might have improved the outcome just a little bit. So let's talk to Billy Bob. Hey, Billy Bob, you're not in trouble, man. We think you did great. Did you think about this? And Billy Bob may be like, man, I was thinking about that, but I wasn't sure. And it's okay, let's have a conversation about it. Let's make it better. And then let's push it out to everybody so everybody knows, like, hey, remember if you're dealing with this kind of patient, consider this, this, and this when dealing with this kind of patient. So that way everybody can get better at the same time. Talked about a medical director already. Talked about public health. Uh, Everything that is done in EMS is done based on what we call evidence-based medicine. Uh, So research affects EMS through focus on improving patient outcomes and through maintaining evidence-based techniques or evidence-based medicine. So evidence-based process includes forming a hypothesis. So, okay, I think that if we did, this task this way, then we would have better outcomes. Okay, well, let's find out. Let's review the literature. Let's read about it. Let's evaluate the evidence, and then let's adopt it. Let's do it. If the evidence says yes, you're absolutely right. If you do X this way, then you'll have a better outcome. Okay, well, let's start doing X this way every time and see what happens. That's how evidence-based medicine, affects EMS. We already talked about a lot of that during our opening. Okay. Does anybody have any questions over chapter one? Comments, concerns, donations? Going once, going twice. Okay. We'll move right along, and if I'm not going to take a whole lot of breaks on Zoom lecture nights just because we have so much to get through. So if y'all need to take a break, feel free to take a break, uh, and then we will get back to it. Trying to get this shared here.
Well, I did have a quick question.
All right, what's that?
It was about the neat and clean appearance.
Yes, sir.
I I like to have my beard grown out, but I keep it like maintained. Would that fall into that?
Oh yeah, that's fine. Nobody's saying you have to look like, you just come straight out of the army or, you're part of, whatever the case may be. It's just a matter of making sure that you're presentable. Presentable takes on a lot of different forms. The key to that is just don't be gross. Everybody knows what gross is. Everybody knows what, generally is acceptable, unacceptable in a daily life. Uh, if you would go, in public looking a certain way, then generally you're going to be able to follow up to the minimum that standard when you're working. But you want to always strive to be at least look put together. Now, there's nothing about a beard that's not put together. You just want to make sure that you're at least giving some air of professionalism to your patients.
Okay.
Oh. As long as everybody see the screen, yeah, should be able to. Okay. I'm still learning how to use Zoom a little bit, so if y'all get to where y'all can't see something, let me know. All right. So well-being of an EMT. It is very important as an EMT to keep up your well-being. This is a very demanding occupation. Whether you do it full-time, part-time, volunteer, doesn't matter. It's demanding physically, mentally, emotionally. Uh, and if you get to where you're unable to function for any reason or in any way, patients may not get their, they say may, I say will not get the level of care that they need because they're not getting you at your best. You need to always try to maintain and be able to bring yourself to work at your best and, utilize whatever resources you need to do that, within reason. Uh, some ways of maintaining good well-being: maintain solid personal relationships. Have a good support system, have a good group of friends, whether that's people that you meet at work, whether that's people that you already had before you got into this business, whatever the case may be. have a good, solid base of personal relationships. Exercise is a great way of burning stress or getting rid of stress. It's a scientifically proven way to get rid of stress. Uh, it works really well. Make sure you get a decent amount of sleep as best you can. Now, this job is notorious for being horrible on your sleep schedules. For example, I got off a 48-hour shift this morning, and I've had about 2.5 hours of sleep in the last 2 days. But when I'm off, I try my best to make it to bed at a reasonable hour and get at least a good 9 hours of sleep every night. Uh, the better you can eat, the better you can prepare your meals and try and eat healthy, the lower your stress level is going to be because the healthier your body is physically, the healthier you will ultimately become mentally and emotionally. Um, Limit your alcohol and caffeine intake. Use in moderation can help reducing your stress levels. And also make sure you see your physician regularly, go to your regular checkups, and keep up to date on your vaccines. You want to try and keep yourself in as best physical condition as you can. So when it comes down to actually protecting yourself, there's a couple of different things you can have to protect yourself from. Uh, the most common thing you'll come into contact with is pathogens. So pathogens are something that can cause an infection, whether that is bloodborne or airborne. Uh, Pathogens will get you sick. It's the nasty that comes off the patients. Okay, so there's standard precautions that we take with every patient to help protect ourselves from pathogens, help keep ourselves from getting sick. Uh, Most local protocols will determine what that standard precaution level is based on OSHA guidelines and what is needed around that area. Well, pretty common standard precautions is gloves, glasses, and in some cases, surgical or N95 mask, depending on the type of patient you're dealing with. You just want to be able to keep from getting yourself exposed to as much of a pathogen as you can. There's some examples of personal protective equipment. You have your surgical mask, your goggles, a couple different types of gloves, N95 masks, HEPA filtered masks, just to help you from getting exposed to something you don't need to be exposed to. So protective gloves, you need to always try to have vinyl or no other non-latex gloves readily available. There's so many people with a latex allergy, it's just not even worth it anymore. Used to, that was a standard for medical gloves was latex, not anymore. Latex allergies have become fairly common. So vinyl or other non-latex material gloves need to be what's being used. Uh, Gloves must be changed between patients. It's not a should, it's not a recommendation. It should be a shall be changed between patients. You don't want to get the blood of one patient onto another patient because now we've just cross-contaminated them for no good reason when we could have just thrown on another set of gloves real quick. So the way you want to take your gloves off is take one glove off by folding it out and down like they're doing there, putting that in your other in the hand that still has a glove, and then take and fold it down the same way. So now they're folded up inside each other, and then throw them away. Make sure you wash your hands in between every call with soap and water, and then use alcohol-based hand cleaners as often as you feel you need to, or if soap and water is not available. I'll go over that. Y'all know how to wash your hands. Uh, Eye protection will prevent anything from splashing, spattering, or spraying fluids from getting into your eyes and thus entering your body. Uh, the best type of eye protection will provide a guard from the front and the sides. So a lot of people have seen safety glasses got that little piece of plastic on the side. That's why keep you from getting hit from the side with some sort of spray back from a patient. In cases where there's any kind of blood fluid spatter, a surgical type mask is recommended just to keep stuff from getting into your mouth. Uh, if there's cases where there's an airborne disease such as tuberculosis is suspected, N95 or a HEPA respirator is recommended just to keep you from breathing in those particles. It's recommended that you wear a protective mask and face shield or goggles whenever you're suctioning a patient, just because you want to prevent a bunch of fluids from getting thrown in your face. Remove some cases where you also have to wear a gown. If somebody has what's called contact precautions, which means that They have some sort of disease that it spreads just simply through basic contact, simple touch. Uh, there's a couple different types of diseases like that that we'll get into. Then you may end up having to wear a gown to protect yourself whenever having to provide care for that patient. So some diseases of concern in EMS is hepatitis B and C. Hepatitis is an infection that will cause an inflammation of the liver. It can start attacking the liver in a variety of different ways. Hepatitis V is deadly and used to kill healthcare workers by the bushel before a vaccine was readily available. Hepatitis C poses the same risk that hepatitis B does, but there is not a vaccine yet for it. That's why it is extremely, extremely important that you wear your personal protective equipment at all times when dealing with patients. Tuberculosis will infect lungs. It's an airborne disease that is highly contagious. HIV and AIDS is a bloodborne disease that will, if you come in contact with a patient's blood and it somehow enters your body through a cut, open wound, sore, a scratch, whatever the case may be, that poses a pretty real danger to you if you're not careful and wearing your protective equipment that covers that. Ebola's not that big of a concern. Neither are those. Influenza has been around for hundreds of years. There's a flu shot. We get it every year. It's the flu. Uh, but when dealing with somebody with the flu, just take your precautions. Wear your mask, wear your gloves, wear your goggles. Just keep yourself from getting yourself sick. And also, you don't want to bring any of this stuff home to your families or your friends or anything else. You don't want to, you know, catch a disease at work and then carry it home and give it to everybody in your household. It's not going to be a good thing. So, EMS personnel and other healthcare workers are at high risk of coming in contact with infectious diseases. Uh, Surprise, surprise, we deal with sick people. We're at risk of getting sick. Uh, the guidelines for workplace safety is developed by OSHA and the CDC. The OSHA standard, just one second. The OSHA standard on bloodborne pathogens requires infection control to be the joint responsibility of the employer and the employee. So what that means is that it is your responsibility just as much as whoever you're working for to prevent it from happening in the first place, a bloodborne exposure. But if it does happen, it is the responsibility of your employer to provide follow-up care, monitoring, documentation services of all of this. Uh, that's why employers must have an infection exposure control plan, which means if you're exposed to some sort of potential disease or bodily fluid that comes in, enters your body somehow, so it's spit in your face, blood gets in you somehow, it happens. It's a nasty job sometimes. It's you need to be able to follow that infection exposure control plan and receive testing and follow-up treatment as necessary. One thing that kind of developed out of that is the Ryan White Care Act. So the Ryan White Care Act essentially provides some protection for EMS uh, if they have been exposed to potentially life-threatening diseases while providing patient care. It means that we are entitled to receive that information from the hospital about whether or not a patient has a potentially life-threatening disease, and then we are able to receive treatment and testing based on that. It is recommended that you receive all the basic vaccinations that you need, whether that's for hepatitis B, the flu, uh, receive TB testing is going to be required most everywhere you work. And then other local protocols may vary about what they require and what they don't require as far as vaccination goes. But an animal service or an EMS agency or government agency can absolutely require you to have certain vaccinations to work there, especially if you're going to be interacting with the public and potentially putting yourself at risk. Stress is inevitable in this in this profession. Recognizing signs of stress and developing strategies to deal with it are very important to the EMS career. You need to have some sort of coping mechanism, and it needs to be a healthy coping mechanism. Excessive drinking is not a good coping mechanism. Uh, You need to have a healthy hobby. You need to have a support system, people that you can talk to. You know, other people in this field are great because they kind of understand a little bit, and then you can talk to them and offload, some stuff that's bothering you. Maybe y'all can talk it out. Uh, EMS providers also must maintain a certain level of mental toughness or resilience to help overcome tough situations. Uh, Resilience doesn't just mean you can deal with it and you get over it and you ignore it. It just means that you understand it and then you are physically and mentally able to respond to it using healthy techniques and coping mechanisms. Doesn't mean that you just stuff it deep, deep down in a place where it's not going to hurt you until you have a heart attack in 30 years. It just means that okay, this is some bad stuff. I'm seeing some bad stuff. I know how to deal with this bad stuff. A couple different aspects of stress that you'll go through in this job is your first state is your alarm reaction. That's your fight or flight. You just roll up on an oh my Jesus type scene. It's absolute pandemonium. Okay, this is where the metal meets the meat. It's time to figure it out. Second stage is your stage of resistance. That's your coping mechanism. And third stage is a lot of times going to, hopefully, you never get to this point, it's where you get to the exhaustion stage. You've lost the ability to resist or adapt to the stressor, and it is essentially bettered you. And this is the point where you need to seriously consider getting some help. Stress reactions could be the result of a critical incident. So some sort of very bad call that you go on, something that very low frequency type call, but very high stress. So, a very serious traumatic injury involving a small child. And it's not a very common, scenario, but it could be something that could seriously mess with somebody. A very traumatic scene involving multiple patients. Again, not overly, common in relation to everything else we do, but it could, instill enough stress that it really bothers somebody, and that's where you need to not be able to cope with it and know how to deal with it. Post-traumatic stress disorder is something that EMS providers are often diagnosed with. Uh, the signs and symptoms of that disorder are often not evident until long after an incident. A lot of times it may be something that you didn't think bothered you that bad. And then all of a sudden, 3 years later, you start having some problems that are directly related to the stuff you saw or had to do or, bear witness to, on that call 3 years ago in a place that you may not even work anymore. Uh, delay, the delay in this reaction makes recognizing the issue with it that much harder. Uh, and a lot of times it will require some sort of intervention by a mental health professional, whether that's counseling or whatever the case may be, but it needs to be addressed. Uh, Cumulative stress reaction is the result of a lot of time doing this. Uh, so many years of, like I said, low level stressors will lead to burnout. So think of it like you have a glass of water, okay? You have an empty glass, let's say an empty glass. And every time you go on something that's stressful or something that's horrible, you add a little drop of water to that glass. And then you add a little more drop of water to that glass the next time. Then another splash here, splash there, a big pour here, a little pour there. Okay, eventually that glass is going to fill up and eventually it's going to overflow. And that's where you start getting into the burnout stage. Uh, some early signs of this, you have some vague anxiety. So it's just kind of a generalized, you're always kind of on edge. Uh, Boredom, apathy, you don't care anymore. Okay. And that's one of the most common and easily recognizable signs of this is you just don't care anymore. Your partner can see it, your patients can see it, everybody around you can see it because you've lost your compassion. And a lot of times that results in your loss of ability to effectively deal with people. A lot of times that will progress to physical type complaints, you know, aches, pains, ailments, loss of emotional control. Uh, Stuff may just send you over the edge for no real good particular reason. Irritability is a pretty common sign of burnout. You're just mad all the time that you're at work. Uh, In serious cases, it can present as, with suicidal type thoughts that may require some long-term psychological type intervention. You want to try and stop it before it gets to this point. You want to try and catch it and identify your stress before it gets to your cumulative stress reaction phase. There's a couple different types of stress that you'll deal with. There's eustress, which is a positive form of stress. It helps people work under pressure. So that's, your driving force, your good factor is like, okay, I know this is bad. I know this is serious. That's what means I've got to move fast. Okay, that's what means I've got to do this and I've got to do this well. Then there's distress, which is a negative stress that causes immediate and long-term problems with health and well-being. That is your stress reactions to things that are not healthy. We talked about that already. Talked about a lot of those already. A lot of systems have started instituting a critical incident stress management type response to bad critical incidents. This is a comprehensive system. It is composed of other responders, mental health professionals, everything from the ground up, and involves education, resources to prevent stress. It involves a team that can come out and deal, with a crew or a shift that was involved in some very bad stuff. They can come down and sit everybody down, and we have kind of a big talk, let's talk about it kind of session. And then a lot of times they will offer ways to deal with stress appropriately as it occurs in your life. Uh, this is done through what's called a critical incident stress debriefing. Uh, so where it helps responders to diffuse after an incident, and like I said, helps responders deal with stress. So reactions to death and dying is something you'll have to deal with as a provider and something you have to be able to recognize in patients and their families. So the emotional stages of death and dying, there's the denial stage. So this can't be happening to me or this isn't happening to me stage. There's the anger or the why me stage. There's the bargaining. So, okay, but first let me do this. Let me at least make it to my daughter's wedding. Let me see my daughter walk down the aisle and then I'm good. Or let me get to my son's graduation, whatever the case may be. Then there's the depression phase, this, okay, I get it, I'm dying, but I haven't even got to, go see, whatever. And there's the acceptance phase. That's where they've come to terms. It's okay. I'm not afraid. I know this is about to happen. I'm about to die. When dealing with a patient, you need to be able to understand their reactions, recognize their needs, be tolerant of angry reactions from patient or family members, to the point where it doesn't put you in jeopardy, but, recognize that it's not personal. Listen empathetically if they're trying to talk to you. Don't falsely reassure them, and only offer the comfort that you realistically can. Never tell somebody that they're going to be okay. Don't do it. Don't ever tell their family members that they're going to be fine. Don't do it. Because even if you believe that, even if you think, okay, they're going to be okay, what happens if they don't? What happens if on the way to the hospital, they throw a clot and they die? Okay. And they get to the hospital behind you and you pull them out doing CPR and they were just fine a minute ago. And you told them they were going to be okay. Now they blame you. Okay. Never tell somebody they're going to be fine. Never tell somebody they're not going to die. Uh, Tell them, we're going to do everything we can. We're going to do everything to the best of our ability. Never say you're not going to die. Never say you're going to be okay. Don't say that to patients ever or their families. When dealing with safety and safety, EMS is not usually a dangerous profession. However, we are sometimes involved in dangerous things. Uh, that's why you need to be able to be aware of potential dangers at all times. Uh, and determining your scene safety will be the most important decision you make upon the arrival of any call. Scene safety is a ever-changing thing and is not a one-time, let's assess this. A scene can initially be safe and become unsafe, and it can happen very quickly. Uh, I've had everything from pots and pans to knives and guns involved in negative ways towards me on scenes. And those scenes were initially fine when I got there. So always be aware of your scene safety. And if you are in an unsafe situation, remove yourself and your partner, and if possible, your patient from that situation, unless the patient is the one making the scene unsafe, and then just leave. Call law enforcement, let them secure a scene. Okay. Dealing with hazardous materials incidents, the most important thing you can do is don't go near it. Maintain a safe distance from the source of the hazardous material. I'm going to post a video along with some of these chapters as we're actually going to get into some more hazardous materials type stuff later on in this course. And I'm going to post a video why you don't just walk up on there. Ensure that your emergency vehicle has binoculars and an emergency response guidebook. Most people in here who have been or are firefighters and law enforcement officers have some basic understanding of a hazmat incident and what to look for. I don't know if we've got any hazmat technicians in the class. I have no idea. But uh, generally, if you're not a hazmat technician, you're not going up there. Uh, Even if you are a hazmat technician, if you're working on an ambulance, you probably don't have the things you need to handle a hazmat incident. So it doesn't matter. It's like an off-duty paramedic with a pair of scissors in his pocket going into Walmart and expecting to be able to run a code. Doesn't work that way. So make sure you have what you need to respond to a hazardous material incident, which is binoculars and an ERG. Your role on a hazmat scene is recognize any potential problems, take actions for your personal safety and safety of others to the best of your ability, and then notify a trained hazmat response team, whether that is your fire department, whether that is a mutual aid agreement you have with a department that has a hazmat technician team, whatever the case may be. But do not, under any circumstances, treat any patient until they have been decontaminated if they were involved in that hazmat scene. Now, if somebody collapses not involved in the hazmat scene, okay, you don't have to wait for somebody to scrub them down. But if they are involved in this hazmat incident, do not, under any circumstances, treat them, touch them, do anything to them. Do not put them in your ambulance, your fire truck, whatever the case may be, until after they have been decontaminated. If you do, all you have now done is contaminated your ambulance, yourself, your partner, all of your equipment, potentially caused a serious health hazard to you and your partner and anybody else in that ambulance, the emergency department staff, so on and so forth. You've potentially contaminated anywhere from 2 to 20 people. Wait for them to be decontaminated by the hazmat team or the fire department or whoever's doing that before you ever offer any kind of treatment. This guy does not want to be a blue canary, so he's standing back with his binoculars. Good on him. If responding to a terrorist incident, recognize that it may be small or large in scale. It may include chemical agents, biological agents, radiation, weapons, and/or explosive devices. And it does not just happen in large cities. There was a mass shooting in Fordyce, Arkansas, 2 or 3 days ago. Okay, it happens anywhere and everywhere. You need to be ready to respond to it. Rescue operations include rescuing or disentangling victims from fires, auto collisions, explosions, electrocutions, and more. Don't basically the gist of this is don't perform anything that you're not properly trained, and I would add properly equipped to do. Goes back to what I said earlier. Does not matter if you've been through 19 different Corps rescue classes and you hold a 72 certificates from Arkansas Task Force One. If you don't have the equipment you need, you are useless until that equipment gets there. So don't go trying to MacGyver some stuff because all you're going to do is get yourself hurt and you then become part of the problem. Dealing with violent situations or violent scenes, you need to have a plan in place with you, your partner, your crew, your fire department, whatever the case may be. Law enforcement, I know if law enforcement officers in this class have a different role in this. But as far as EMS goes, have a plan, wear safe clothing, prepare your equipment so it's not so cumbersome. Carry a portable radio at all times if possible. Don't enter a scene without a portable if you can help it. And then decide on your safety roles. Decide what you're gonna do if this scene turns sour. Uh, Survey your scene on approach. Uh, don't announce your arrival if you can help it. I generally, on every call, I will turn off my lights and sirens before I make it to the scene. Uh, just gives me an extra second to look around and make sure I'm not walking into some nonsense. Observe for any signs of violence, struggle, fights, blood, whatever the case may be. Any indications of a crime scene. Observe for any obvious alcohol or drug use, any weapons you can see present or potentially that are concealed. The reactions of family members, the demeanor of bystanders, any potential perpetrators or pets at the scene. So, vicious dogs, aggressive animals, things like that. Uh, when you knock or ring a doorbell on any scene, don't stand directly in front of the door. Uh, Also, would wager, probably don't be holding a flashlight directly on your partner, like this guy right here is doing. Uh, the reason being is if somebody has decided they're going to call 911 with the purpose of killing responders, it's happened before. They hear you knock on the door, they just start shooting at the door. You have a whole lot better chance of surviving and not being critically injured if you're not standing directly in front of that door. So every time I approach a house, whether I'm working in EMS, fire department, or a law enforcement role, I stand at the door jamb, I knock, I announce, I knock on the door, ambulance service, EMS, paramedics, whatever I decide to say at that particular moment in time, and I wait for them to acknowledge me. And then before I make entry to the house. So in order to react to danger, remember the three R's: respond, radio, and reevaluate. Uh, there's an unofficial fourth R, which is run. So respond to the scene appropriately. So it means that if you notice the scene has become unsafe, it's time to leave. It's time to leave. Defend yourself if you have to. Don't seek out a physical altercation, but also don't just get beat up if you can defend yourself. Radio in what's going on. Tell dispatch you need law enforcement there. PDQ, and then reevaluate what is needed by that scene. Do not re-enter a scene until it has been secured by law enforcement. Never enter a scene that's potentially violent until the police have secured it and told you it's safe. For example, if you're dispatched to a shooting, don't go rolling up in that shooting if there's no law enforcement on scene. Don't go rolling up into that shooting until law enforcement on scene tells you to come into the shooting. Because what you don't want to do is come barging up in there trying to be a hero with your little jump pack, and now you get shot because the guy's still there. Very much bad day for us. You want to flee whenever possible, get rid of any cumbersome equipment, and take cover and conceal yourself. Uh, I'll talk about this very briefly. Difference between cover and concealment. Cover is something that is hard and will stop bullets. It is something that you can get behind that you will be able to be relatively safe. Concealment is just something that you hide behind, something that tries to block you from view. All right. Anybody have any questions over chapter two? Comments, concerns, donations?
I don't think so.
All right, get this next one. Chapter three is covering lifting and moving patients. So once again, the most important thing we can do is protect ourselves. We do this when lifting and moving patients by utilizing proper body mechanics. Uh, Body mechanics is the proper use of your body to prevent injury and to facilitate lifting and moving. So you want to consider things before you go to lift any patient. Uh, the patient's weight or the object's weight, and can you lift it? What are your limitations? If you need help, call for help. If you need a lift assist, call for other ambulances, call for other fire departments, law enforcement. Do whatever you've got to do to get somebody there to help you lift. Do not blow your back out. It's not worth it. Trust me, I've done it. Uh, make a plan, communicate it with your partner. Uh, Say, okay, we're gonna discuss how we're gonna lift this patient, discuss what we're gonna do once we get them up, how are we gonna move them out to the ambulance, how are we gonna move them up to where we need them to be. When lifting, make sure your feet are positioned properly. Lift with your legs, never with your back. Do not turn or twist, and do not compensate when lifting with one hand. You want to position weight as close to your body as possible. If you're carrying a patient down the stairs, you want to try and use a stair chair whenever possible. That's a stair chair. When reaching, try and keep your back in a locked in position. Avoid twisting while reaching. Avoid reaching more than 20 inches out from your body. Avoid any kind of prolonged reaching if there's any kind of strenuous effort required. If you're going to have to reach that far to get somebody, then maybe let's reevaluate how we're doing this. Uh, Always push rather than pull whenever possible. Keep your back locked in. Keep line of pull throughout the center of your body, and keep the weight close to your body. If the weight is below your waist, don't bend over, kneel. Push or pull from a kneeling position. Avoid pushing or pulling overhead when possible. Keep your elbows bent and your arms close to your side whenever possible. You want to try and get as low of a center of gravity as you can to avoid throwing your back out. So there's a couple different ways we're going to move a patient, a couple different categories of moves when dealing with patient. So the first and least pretty one is an emergency move. All right, so the scene is hazardous. Uh, in order to provide any kind of life-threatening care, you got to get the patient out first, or you must reach other patients who are more critical. So, for example, if you arrive on scene of a motor vehicle accident and you notice that the engine compartment is starting to smoke and you believe this vehicle is about to catch on fire, if you can go ahead and snatch the driver up, then we're not worried about spinal precautions. We're not worried about, if we potentially cause another minor injury in the process, we're jerking them out the car and moving them away before that car catches fire. Uh, that's kind of an extreme example, but just anytime you got to get a patient out of a hazardous situation, when it's safe for you to do so, it's called an emergency move. Covered in ways to do an emergency move, you can do a closed drag, an incline drag, firefighter's drag, blanket drag, one rescue assist, just kind of helping him hobble away. He looks like he hates his life. Two rescue assists, where you place the arms around the shoulders of both rescuers and y'all hobble up out of whatever the emergency is. And then there's an urgent move. So an urgent move is not a jerk in, let's jerk them up and get them out of there. It's usually patient's in a position where you can only provide treatment if the patient's moved or other factors at the scene are starting to cause the patient to decline. So we need to get them out of there before stuff starts getting worse. Uh, Usually will involve moving the patient to a backboard, getting them out of a situation. A non-urgent move is the most common type of move. There's no immediate life threat. Patient can be assessed, treated, and moved in a normal way, right where they're at, or whatever the case may be. And then you take all precautions not to aggravate any existing conditions. So where we stop, we take our time and make sure we don't injure them in the process, uh, and we get them out of there safely. A lot of patient carrying devices that you'll end up having to use throughout your career in EMS. Wheel stretchers are kind of the most iconic ones everybody sees all the time. There's your power stretchers and then your manual stretchers, which the only difference is one is battery operated, one is U operated. There's bariatric stretchers, which are designed to carry people of larger stature. Most of them are rated to carry patients weighing up to 800 pounds or more. A lot of times, those will be manual operated cots that are usually attached to some sort of pulley system to help get them into the ambulance. So that's a wheeled stretcher. That's a battery operated wheeled stretcher. Another power stretcher. That's a bariatric stretcher that I was talking about with the kind of the pulley method they're using. Looks like he's grabbing that winch out of the top of the ambulance there. He's going to hook it in there to kind of push it, pull it up the rest of the way. Stair chairs, we saw those earlier, are good for when moving people down the stairs. Don't carry your stretcher up and down stairs. They're heavy. It's not worth it. Uh, there's two couple different types of spine boards. You're rarely going to see a short spine board, but you will see a long spine board pretty regularly. In fact, it's one of the skills you have to get checked off on before the end of this class is the use of a long spine board. Uh, Anymore, used to, we would use a long spine board anytime somebody had a neck or a back injury. Anymore, it is primarily for removing patients from a vehicle only when a neck or spine injury is suspected. And usually they don't stay on it after we get them out of the car. There's a stair chair, long spine boards. A couple other types of stretchers you may find yourself using: a portable stretcher, a scoop stretcher, basket stretcher, flexible stretcher, or a vacuum mattress. So it's a scoop stretcher, or sometimes called an orthopedic stretcher. A lot of times we'll use this to pick somebody up if they've got some sort of pelvic or hip type injury or femur injury, just because it does not involve moving them very much. A lot of times when we get there on those types of injuries, they've already placed themselves in a position that's most comfortable for them. And so we want to try and avoid aggravating whatever injury they have. And so this actually breaks apart in two pieces. And then you do just like you think, you just scoop it and then latch them together and just pick them up. It's a basket stretcher or a Stokes basket called some places. You'll a lot of times you'll see this in like rescue type situations. Some fire departments carry them on ladder trucks for extrication of victims. A lot of search and rescue teams will have these for wilderness rescues. They're handy in certain situations, but they're not always the most practical option. A flexible stretcher, or it's kind of like a litter or a gurney. A lot of times those will fold down in half. And they're good. You'll see those a lot in like mass casualty situations or field treatment type situations. Vacuum mattress, you don't really see these very often, but a lot of times it's just used like kind of a slide deal. If you're moving a patient with suspected spinal injury, you're going to mobilize the head, neck, and spine before you move. Uh, with manual stabilization, a rigid cervical collar or C collar restrict the movement of the neck and spine. We'll talk about that more as we get into trauma of the head, neck, and spine. Uh, If you have a patient with no suspected spine injury, you can lift them by using the extremities. Uh, this can be an extremity lift is used to carry a patient to a stretcher or stair chair. That's a common type of extremity lift. We just get up under their arms, up under their legs, pick them up, walk with them. There's a direct ground lift, which lifts from the ground to the stretcher. Two rescuers get up under them, get up under the patient, working together, stand, lift at the same time, lifting with their legs, not their back, stand up, place them on the stretcher, just like that, just like that. There's the draw street method, which is oftentimes used to move somebody to a stretcher or to the hospital bed from the stretcher. Uh, Take them on the sheet that's already under them and just slide them over. Nice and easy. We'll talk more about the recovery position later. So I'm transferring a patient from a EMS stretcher to a hospital stretcher. Position the raised ambulance cot next to the hospital stretcher. Uh, Make sure the hospital bed's ready to receive the patient. Grab the sheet on either side, pull it to you. There's that. Ready to go. About any questions over lifting and moving patients, we're going to practice this a lot on our skills day as well. Comments, concerns, donations. We're moving right along. So if y'all have questions, please feel free to ask them. If you feel like you're missing something, this video will be posted so you can go back and review it later. So chapter 4, medical, legal, and ethical issues. So your scope of practice is something you're going to hear a lot in EMS jargon and talk, and when dealing with especially new protocols, stuff like that. So it is defined as the regulations and ethical considerations that defines the scope or the limits and extent of an EMT's job. Uh, Basically, it is what you can or can't do at certain levels. If you can do it, it is within your scope of practice. If you can't do it, it is outside of your scope of practice. Generally, this is going to be defined by state legislation, regional rules, guidelines, and local protocols. A standard of care is another important term to remember, is the care that will be expected from any EMS provider with similar training when caring for a patient in a similar situation. It is what you can expect to receive. It is the standard for what you should be receiving every time. Basically, your scope of practice is what you can do. Your standard of care is how you should do it. All right. Patient consent is permission from the patient to assess, treat, and transport. A couple different types of consent. There's expressed consent, which is informed. We talk about it, you agree to it, you give me permission to do it. Okay. We talk about your treatment, your transport. You say, yeah, I want to go to the hospital. Yeah, it's fine. Go ahead. We're going to do this. Great. I've got your express consent because I've told you what we're doing. Implied consent is assumed consent. Uh, Implied consent is generally used for children, mentally incompetent adults who otherwise are not legally permitted to provide consent or refuse treatment. Uh, there are certain exceptions to this we'll talk about in a second, but generally it is whenever it is implied or assumed that a reasonable person would want care in a certain same situation. Basically, it means that if we respond on a call at a school or we respond on a call, just say randomly at a gas station, and there's a child there by themselves for whatever reason having a medical emergency, we don't have to wait on the parents to get there because under the doctrine of implied consent, we would assume that a reasonable person in the same situation would want us to take care of and treat and transport their child. So therefore, we have operated under implied consent. Uh, there's a couple possible exceptions for this. One of them that's applicable in Arkansas is in loco parentis, which is a Latin term, basically means in place of parents. This a lot of times you'll run into in schools uh, or other care type facilities where school staff or care center staff, daycare center staff, whatever the case, has been given permission or authority from the parents to make medical decisions for their child while they're in their care. Another exception to this rule is emancipated minors are legally allowed to make their own medical decisions. Emancipated minors are generally those who have had a child, got married, joined the military, something like that before their legal age of 18, and are for all intents and purposes considered an adult after that.
Oh, transport, you know, they're marking a hit on this on mother signature.
Marshall, I'm having a real hard time hearing you, man. What are you saying?
I said, if they mark an X on their consent, if they refuse to go, is that just as good as them signing their name?
Yeah, we're going to talk about refusal in just a second. The next couple
Okay.
slides are about refusal. So, when dealing with consent involving children, mentally incompetent adults, some possible exceptions for obtaining consent is life-threatening illness or injury. Uh, we generally don't have to wait around to get consent for that. We can just deal with it because again, it goes under implied consent. A reasonable person in the same situation would expect us to provide care for this person. And then the minors who have children or minors serving in the armed forces are the emancipated minors, like I talked to you about a second ago. There are certain situations where we may provide involuntary transportation. Uh, we are authorized to do this by law if a patient is considered a threat to themselves or others. So your suicidal, your homicidal patients, your patients who are unable to make, at that point, you're unable to make decisions for yourself because you're a danger to yourself or you're a danger to others. And so we can force you or compel you to go to the hospital. Uh, a court order. So if we have a court order to transport you, like this usually can be used for psychiatric type patients, then we can transport you against your will. Uh, or if given a decision by a mental health professional or police officers in the state of Arkansas can have people involuntarily sent to the hospital for mental evaluation. Uh, or if the patient is restrained, if you have to restrain the patient during involuntary transport, make sure that you are still monitoring that patient's health and well-being during this time. They're not going to like you. They're going to call you everything but a child of God. You still got to take care of them. All right. When dealing with refusals of care, so a patient may refuse care or transport under the following circumstances. The patient must be legally able to consent. All right. Patient must be awake and oriented, meaning they must be of sound mind. They must be fully informed of what they are consenting or what they are refusing and the possible ramifications of refusing that. And they will be asked to sign a release form or a refusal. If possible, you want to try and persuade the patient to accept care and transport. It is less of a liability than refusing treatment and transport. Spend time speaking with the patient. Generally, they called you out there for a reason. Most of the time. Sometimes we get called out there for nonsense. Generally, they called you out there for a reason. That reason is usually because they think they need some sort of medical care. Granted, we can provide some limited forms of medical care, uh, but we cannot provide medical care that's given by a physician. So try and get them to go with you. Try and determine why they're refusing care, if they're refusing care, and then inform the patients of the consequences of not going to the hospital. It's an essential component of every refusal care situation. Be like, look, you're accepting all liability and risk of this up to and including death. Consult medical direction if need be, and then ask the patient if it's all right. If you call a family member, advise the patients that you would like to call a family member just to get a witness that they did not want to go to the hospital. Uh, Call law enforcement personnel if necessary to witness, and then ask the patient to sign the refusal of care form used by your agency. If a patient does refuse care and is competent and willing or is competent and able to refuse care, subjecting the patient to an unwanted care after they've refused unwanted care and transport uh, can be viewed in the court as assault or battery, depending on your state. Uh, that's why it's important if they say no, that means no. We can't just keep going on them after that, unless we're under one of those circumstances we talked about earlier. Have a witness to a refusal to protect you, and then inform the patient that if they change their mind, to call back. Encourage them to call back if they change their mind. And then document all your attempts thoroughly and recommend somebody remain with the patient, like a friend or a family member. When other circumstances you may have to deal with in a legal aspect when providing patient care is a patient who has a do not resuscitate order or a physician order for life-saving treatment or a living will. Uh, it's a legal document expressing the patient's wishes as the patient's unable to speak for themselves. Uh, Most common one you see is a do not resuscitate order. It's usually part of an advance directive or maybe part of a POLST, or in Arkansas it's called a living will. Basically, what this means is that if a patient goes into cardiac arrest and they do not want any kind of resuscitative measures, or they only want certain resuscitative measures that will be clearly outlined on the form, and it is a legal document and you are obliged to follow. We're talking about legal ramifications. Negligence is something that should have been done and either was not done or wasn't done right. In order to prove negligence, you must prove that the EMT had a duty to act and then breached that duty, meaning they failed to provide that standard of care that we talked about earlier, or failed to act altogether. Is considered negligence. You also must prove that the patient suffered harm because of the EMT's actions or inactions. Negligent EMTs may be required to pay damages and can be held civilly and criminally liable. Another legal term you need to be familiar with is a duty to act. Uh, a duty to act is an obligation to provide care to a patient. It is not always a very clear role. So, for example, if you're off duty, do you still have to identify yourself as an EMT and provide care if you roll up on something? I don't know. Maybe, maybe not. Generally, it's going to be covered under your local protocols, local policies. In the state of Arkansas, you are considered to have a duty to act once you have identified yourself, but not before. So if you have identified yourself as an emergency medical technician or a paramedic or an RN or a doctor or whatever, a medical professional of some kind, then you then have a duty to act and a duty to provide care until you are hand off that care. Uh, Also, you want to also make sure you follow your own conscience. Are you okay with not providing care? Are you okay with just rolling past that bad accident that you just watched? Or do you feel like you need to stop and render aid? Another term, abandonment. Go ahead.
Uh, I'm sorry to interrupt. I actually had a question about that.
Go ahead.
I have a friend and he's a paramedic and he has like the sticker and everything on the back of his truck. And he actually rolled past, it was about a year ago, um, an accident, and a couple police officers saw it, and they one actually like chased him down and asked why he didn't pull over, and he thought I was going to get in trouble. Is that like a legal issue?
So the issue with like stickers and shirts and stuff like that is anybody can get them and anybody can put them on. And if you have friends or family members that may be using your vehicle that has a sticker on there, they're not under a duty to act just because you're a paramedic with a sticker on your car. So I would say that just having a sticker on your car doesn't identify you per se as an emergency medical provider. Generally, you would have to identify yourself, be like, hey, I'm an EMT, I'm a paramedic, whatever the case may be, uh, would generally be what I would consider identifying yourself. But that just goes back to you got to follow your own conscience on whether you stop or don't stop as well.
Okay, I was just curious about that.
Yes, sir. Another term you have to learn and know about is abandonment. So, abandonment means once care is initiated, it can't be discontinued until it is transferred to medical personnel of equal or greater training. Failure to do so may result in abandonment and can also result in civil or criminal penalties. All right. So, some stuff that we talked about some scary stuff that hurts us. Let's talk about some stuff that protects us. So, Good Samaritan laws grant immunity from liability if a rescuer acts within good faith and within the level of training. It may not always cover an EMT in some situations. For example, generally it will only cover acting in an off-duty capacity or acting in a rescue capacity, meaning that you saw something or you came upon something and you stopped to help. Whether that's an automobile accidents, medical emergency in a grocery store, whatever the case may be, and you stop to help. Uh, it does not, contrary to popular belief, protect you from gross negligence. It does not protect you from any violation of the law. So if you stop to help and you just do some off the wall stuff that you saw on Grey's Anatomy and you cause harm to this patient, still gross negligence, still going to be problems. It does, however, protect you from any kind of civil liability if somebody's like, well, this guy stopped and did this, that, and the other, and now my arm kind of hurts a little bit, but you didn't do anything wrong. Protects them from coming back against you. Confidentiality is key on a lot of stuff that we do. Uh, any information on a patient's identity, history, condition, treatments, all considered confidential information. All of that is HIPAA protected information. HIPAA is another term you need to be familiar with, another word you need to know. HIPAA stands for the Health Insurance Portability and Accountability Act. Uh, HIPAA protected information may be shared only with other healthcare personnel as part of the patient's continuing care. Otherwise, it must be obtained through a subpoena, and the patient can also obtain it themselves through requesting the record. And we'll talk more about HIPAA stuff as we kind of go through things. Medical identification devices is something else you need to be aware of. A lot of patients are starting to wear those, something you need to look for during your assessment. Some of these may constitute special situations that you need to be aware of. Uh, So they may indicate a particular medical condition, such as a heart condition, an allergy that they have, diabetes, epilepsy. Usually sometimes it'll be some sort of indication as to why they have suffered some sort of medical emergency, especially if they've just fallen out and gone unconscious or whatever the case may be. Dealing with organ donors, if you have identified somebody as an organ donor by their driver's license, information you can pass on to the hospital, especially if it's a critical patient that may not make it. But hey, this guy's an organ donor, just letting you know. Something that's also kind of got a lot of publicity here lately is safe haven laws. Arkansas does have safe haven laws. You've seen the baby boxes. That's what is protected by these. So it allows a person to drop off an infant or child at any, emphasis on any, fire, police, or EMS station, manned or unmanned. So those of you with volunteer departments, they can still drop them off there. Something to be thinking about. You've seen the safe haven baby boxes that are going into a lot of fire stations. We're getting one at my local fire department very, very soon. It's currently being installed, as a matter of fact. Uh, a lot of departments are getting those just because it's a safer option than somebody just trying to leave them at the doorstep or, toss them in somebody's truck or whatever the case may be. Different states have different guidelines for ages of children that are protected. I don't know what Arkansas's cutoff age is, but its goal is to protect a child who may be abandoned or harmed by a parent who is unwilling or unable to care for them. It's to stop parents from just throwing away their kids because they decided they didn't want them. You may be called to a crime scene well, I say this, you will be called to a crime scene at some point in time in your career. Uh, Once the police have made the scene safe, your only priority is patient care. You do, however, need to know what evidence is and take reasonable steps to preserve evidence. Patient care and life safety always come first. If you've got to destroy some evidence to provide patient care, sorry. But if you don't have to destroy something or you don't have to tamper with a scene in order to provide patient care, then don't. And we'll talk about that a little bit more as we start getting into especially some trauma type stuff. So examples of some evidence, the condition of the scene may be evidence in and of itself. So if you have knocked over tables, chairs, busted out windows, the patient may have evidence on them. Not all of that blood may be theirs. Fingerprints, footprints, it's bloody footprints in and out of a scene. And then there's microscopic evidence that we will tamper with if we just start touching stuff that we have no business touching. Uh, Remember what you touch. Try and come into a crime scene the same way that you go out of a crime scene. So follow the same tracks and then work with law enforcement. A lot of times, if you're on a crime scene, there's going to be somebody keeping a crime scene log. They're going to log who you are, who you're with, why you're in there, what time you came in there, what time you came out. There's going to be somebody watching to see who touches what. Uh, it's a pretty big deal, especially if you start getting into like a big violent crime type scene. As a first responder and EMS provider, you are a mandated reporter. So you are required to report any kind of child, elderly, or domestic abuse, any signs or indications that somebody may be a victim of human trafficking, any type of violent crime injury. You need to be reporting to law enforcement, to the hospital, have them report to law enforcement. Any situation where sexual assault is involved, or any situation where special restraint may be necessary, you should be reporting this to at least to the hospital. Uh, Follow your local laws and protocols on what Arkansas requires you to do, and we'll go over that. You do have some ethical responsibilities as a EMS provider. Uh, you may have some personal opinions about what is considered right and what is considered wrong as an EMT. So ethics are the standard of behavior for a profession. The ethical expectations of an EMT are just to be honest in your reporting, refrain from actions that cause harm to a patient, and work to help the patient. So everybody's heard the phrase "do no harm" is often used by medical students and incoming doctors and stuff. They're sworn to do no harm. It applies to you as well. So do no harm. If you can refrain, you should always try to refrain from actions that will cause harm to a patient. Respect the right of adult patients to make their own decisions. Once again, it goes back to that thing we were talking about earlier. We don't own anything. It's not our, they're not our, the patients aren't our property. Their property isn't our property. We don't get to just barge in there and start making their decisions for them. Most of the time, they're adults. They get to make their own decisions. It's our job to inform them about the best decision they can make and help them with that decision. Treat all patients fairly and justly. Assist others to learn your profession. Report any misconduct and make sure your research is approved. Anybody have any questions, comments, concerns, donations about that?
No, sir. You said you were gonna post this on a link like
Yeah,
this video.
yeah. This will all be posted either tonight or first thing in the morning. It is currently being recorded, but yes,
I was just.
it will
Oh,
be
I'm sorry.
posted.
I was just curious. I just got a text from my mom. Her car just died on the highway, and she couldn't get hold of my brother. That's so I was gonna run up there, and I think her battery might have died.
Yeah, yeah. Go up there and go ahead.
Okay, I was just making sure. I didn't want to just jump off.
Get after it. You're good.
All right, all right. Thank you.
Yep. All right. Last chapter of the evening. I know we've thrown a lot of kind of dry stuff at you. These are some of the boring chapters. We get into more exciting stuff later, I promise. All right. This is a chapter that y'all need to be reading on your own as well and learning a lot of these terminologies or a lot of these terms and terminology uh, because it will affect you on the NREMT exam when you take it at the end of this class. All right. So, dealing with medical terminology, you need to understand the components of medical terms. So, compounds are made up of two or more words, so such as smallpox. Uh, Words are made from parts. So there's root words, roots with combining forms, prefixes, suffixes, basic English type stuff. But you need to understand how that all kind of comes together. So, for example, a combination of roots and suffixes, cardio, which means the heart, logy, which is the study of, and ist, which is one who specializes in. So, cardiologist is one who specializes in the study of the heart. Uh, Acronyms you may see a lot, maybe pronounced as a word such as CPAP, actually stands for continuous positive airway pressure. We'll talk about that when we get into airway, but it's pronounced CPAP. So you have words like cholecystitis. So you have chole, which means bile, cyst, which means closed sac, itis, which means inflammation. If you assemble it, a bile sac inflammation. So cholecystitis is a inflammation of the gallbladder, which stores your bile. So learning and be able to break down your compounds there and your roots and your suffixes. Try not to use medical terms when speaking to patients or family members. Uh, Occasionally use complex terms used in messages can cause confusion even among trained healthcare professionals. Plain talk is usually better. I will sometimes write medical terms in a narrative uh, just because I can use one word instead of four sometimes. But when I'm speaking, when I'm talking, I'm not going to say that there was a distal fracture of the left radial on in whatever the case may be. I'm just going to say he broke his arm. Okay. So for the best case, the best outcome when using verbal communication is just to speak clearly, speak in plain talk. All right. So when dealing with anatomy and physiology, anatomy is the study of body structure, or physiology is the study of body function. Two very important distinctions there. The Some directional terms. Your anatomic position is facing forward, hands at your sides, your palm facing forward. That is your anatomical position. So that is how we refer to everything as we're looking at the patient, is as though they were in that position. When we're describing their injuries and ailments, it is as though they are in that position when we describe it. So you divide the body into planes. So you have a midline plane where the medial, which means medial, is closer to the midline of that, and then lateral is further away from the midline. So if you take a line, draw it straight through your body. Everything that's closer to the center is medial. Everything that's further out is lateral. Bilateral generally means both sides. Unilateral means only one side. I'm not going to spend just a whole lot of time going through every single one of these because this is some stuff that y'all are going to have to read to really understand. But you have some general ones like anterior means front, posterior means back, superior means vertically above, inferior means vertically below. And there should be some diagrams that kind of attach some of these terms to them so you can actually look at a picture when dealing with this. So this is that anatomic position I was talking to you about a second ago. You have the mandible, the neck, cranium and face, their head, torso, and lower extremity. Uh, then upper extremities are considered your arms, hands, fingers, all that good stuff. It's all part of your upper extremity. That is your anatomical position. So midline will be running right down the center of that, just like that. And you've got something that's closer to the center is medial, further away is lateral. So your midclavicular line divides your chest into two regions. Since there are two clavicles, there are two midclavicular lines that runs down each side here, just like it shows right there. All right, so more of your directional terms. There's a couple different planes of your body. There's your frontal plane, which divides straight across, your medial plane or your sagittal plane, also called your median plane, divides straight up and down. Your transverse plane is your horizontal plane, divides kind of side to side. So it's just different ways of being able to break the body down into sections whenever you're performing your assessment or giving your you're giving your reports. Sorry. All right. Dealing with abdominal quadrants, you break your abdomen into four quadrants. So you have your right upper quadrant, your left upper quadrant, right lower quadrant, and left lower quadrant. Those are usually abbreviated as shown here. So if you see any of these abbreviations, that's usually what they're talking about. So it's important to know kind of the organs that are in each quadrant of your abdomen. So your right upper quadrant, you have your liver, your right kidney, your colon, your pancreas, your gallbladder. Left upper quadrant will contain your spleen, liver, another part of your liver, your left kidney, your stomach, your colon, your pancreas. Your right lower still contains your right kidney, part of your colon, small intestines, your major artery, and then your appendix, part of your ureter. Left lower, left kidney, left colon, small intestines, ureter, major arteries, things like that. It's important to kind of understand what's where when dealing with your abdomen. That way, if you have somebody complaining of pain and the severe abdominal pain in the right upper quadrant, well, the biggest thing that we're thinking there is probably going to be some sort of gallbladder issue because it's the most irritable organ in that area. For example, but if somebody's complaining of right lower quadrant abdominal pain, we may think, appendix. That's the most common cause of right lower quadrant abdominal pain. We're going to think about that. And we'll get into that a little bit more as we get into GI stuff as well. That's why it's important to learn your quadrants and what's where when you're studying your anatomy. Some positional terms you need to be familiar with. You have supine, which is a patient laying on the back. Prone, which is a patient laying on the abdomen. Recovery, which is a patient laying on the side. Uh, which that's preferred for any unconscious non-trauma patient. So there you have supine laying straight flat on their back, prone laying face down, and then left lateral recumbent, which is the recovery position. You have your Fowler's position, which is the patient seated straight up. You have a semi-Fowler position, which is the patient leaning back a little bit. Semi-Fowler's is the most common way you see somebody transported on an ambulance gurney. All right. Anybody have any questions over chapter 5? That's going to be one that y'all are going to really need to read. And then if you have questions, you can post them in the group me. If you have any questions right now, obviously you can ask. That's one that y'all really need to hit and study hard on because there's going to be a lot of uh, it's gonna have a lot of effect on everything you do from this point forward, uh, by knowing those terms. Anybody have any questions, comments, concerns, donations?
Yeah, this is Chris. If we want to review this Zoom meeting, if we want to watch it again, where will we
Mhm.
go to watch it?
Well, if y'all think of anything, post it in the group me, and either me or Brandon or Anthony or Cody or somebody answer it for you. I will get this video posted for everybody else who didn't make it on here tonight. And then if any of y'all that need to review it. But I appreciate y'all. And we made it out of here in an hour and 45 minutes. That ain't too bad. So, all right, if y'all don't have anything, I'm gonna get off here. I appreciate it.